Fantastic, fantastic. So, these are trying times, obviously. This has been incredibly disruptive for all of us in terms of our research endeavors. And, we think of research sometimes as collecting data to understand phenomena, but in my opinion, research is hand in hand with clinical care. And so we'll touch base on that today, but it is essential for many of our patient populations that their standard clinical care is supplemented through these research activities. So how to do this safely, I'm going to share, one center's kind of opinions and experience. We'll talk about that today. I've really looked back and decided overall, synthesizing everything that's been ongoing, everything we've been doing, into three just general rules for success. And so far, we're successful. I hope that continues anyway. So I think to understand how to restart really requires us to look back and ask that question, how did we stop? And so this, obviously we all went through this, really a stage one. It was a staged stopping. Stage one for us at the Sanders Brown Clinic started on March 7th, where we began pre-screening for symptoms, travel history for all participants as well as study staff. We apply equal rules to the participants and study staff. We sent a letter out to all participants and study partners, letting them know that we were enhancing our safety precautions. We made sure that we had ample stocks of PPE, hand sanitizer, disinfectants. You guys can all remember that was the era when you could not find toilet paper anywhere. It was important that we would need to know in advance that we could manage participant flow. We began sanitizing all exam rooms between all visits. And we essentially at that time shut down shared spaces. So no longer did we have a waiting room. The waiting room was shut down. People were immediately, when they came through the door, brought to a room and spent their entire experience in that isolated room. We shut down the conference room, moved to Zoom for everything, and eliminated participant lounge. We asked all study partners, of course, many of our participants that come in are in full-blown stages of dementia and obviously aren't driving themselves to clinic, so many of them coming in with a family or caregiver. We, at that time as well, asked all accompanying adults that were not needed for the study visit to please wait in their car or over in Jet's Pizza or wherever else they could find. Things were moving fast at that time. And so it was really just a week later on March 15th that we really moved into stage two, which was stopping of all of our observational studies. So if it wasn't part of clinical care, if they were not receiving an experimental medicine, if it was merely, and I shouldn't say merely because this is really important science as well, if it was an observational study, we sent a uniform letter to all sponsors and began to implement a remote work option to limit staff in our work environment. That worked well for a few weeks, but in late March, really, there was so much that was unknown about COVID. How infective is it? How exactly can we, that was the era of only an N95 can protect you. And we really weren't sure what we were dealing with. And at that time, even though we had many studies that were open label extensions, part of care, that could have actually continued by local and university rules, we put a complete stop to all research activities and did that so that we could acquire data, because how can we design a safety program unless we knew this? We at that time went into a total shutdown of the center, and all of our staff moved to remote working. Now that really only lasted about a week or so before we decided that we needed at least one person in the building at all times, and that's because we were receiving many very important deliveries of study drugs, deliveries of regulatory documents, correspondences with sponsors, FDA, that we recognized we needed to have somebody on staff. And so since that time, roughly the first week of April, there has been someone in the center on a rotating basis at all times. So I think understanding, and for each of you thinking about, how did you stop? And was that successful? And I think, you know, as I reflect on how we approached the situation, I can say there were several important features. One was we stayed ahead of the curve every step of the way. We were safer than what the safety recommendations were. It's a very, very important part of our shutdown plan that we met regularly with all staff, constantly, to discuss where are we, are there safety issues, and we communicated regularly with participants so that they were aware of what we were asking, how we were potentially protecting them, the sponsors, the regulatory agencies. Very, very important. I suspect that most of you went through very similar processes. So we can ask that question. This is the ultimate question, and where we are currently, how should we restart? And I would answer that in a very simple way. We need to stay ahead of the curve every step of the way, exactly as we did with our shutdown. We need to push for, as best we can, a near 0% infectivity rate. You know, there are exposures that can occur. Those exposures can occur in the outpatient clinics. Those exposures can occur in the hospital. They can occur at Kroger. They can occur at Speedway as you're filling up your gas tank. But when it comes to research, we're dealing with a different set of rules. We're dealing with volunteers, people that don't necessarily have to be there. We owe it to them to do our best for safety. And again, lessons learned from the shutdown, we're going to need to meet regularly with all staff, which we do through Zoom meetings every week to discuss the current situation, identify potential safety issues, vet our responses. This is dynamic. It is not a static, I put a plan on paper and I know that it's going to work. None of us have been through this before. None of us have been through a COVID crisis, and certainly none of us have been through a research restart. So we need to think dynamically. The decisions made may need to be changed over time. And again, we need to be communicating regularly with our participants, their study partners, their sponsors, and regulatory agencies. So this really brings me to rule number one. Trust no one. Trust yourself and trust your team. Yes, we have guidances now that have come down from the College of Medicine, from the other colleges, from the VPR's office, and that's great. But at the end of the day, you are responsible for your clinical trials. You are responsible for your staff. You are responsible for your patients. And you're going to need to implement safety measures and a restart plan that is right for you and where you are. And so I'm delighted with the very hard work that's come out of many, Jim Geddes, the CCTS leadership, the VPR's office. I think, you know, we've got a lot on paper, a good working blueprint of a plan, but there's a lot still unknown. And I will comment, not to make political statements, but we've seen across the nation many states that have made repeated errors in judgment and guidance in regards to restart. We've seen the federal government make repeated errors in judgment and guidance. And so at the end of the day, please empower yourselves. Trust no one, trust yourself, trust your team. So we could think about risk benefit, and this is really, really important, certainly important as I put on my, IRB hat, and I've served on the IRB for well over a decade now. I'm one of the vice chairs. We look at every protocol, every research in regards to risk versus benefit, and this is very, very important. So when I look at my own population, I say I have a unique population. They are the elderly that we know are at highest risk for both infection as well as serious complications. And, we can look at that. It's actually interesting. The graphs on the upper right show total COVID cases by age group. And so it is adults, young adults and middle-aged adults, where we see the most number of cases. But if we actually look to the right of that, where we see a percentage of COVID cases by age group, you can see that the elderly are the highest bar. So actually, the elderly are not just at greater risk for adverse side effects and morbidity and mortality related to COVID infection. They actually are more susceptible to the infection themselves. And this likely is related to age-related changes in immune function. We also know that COVID carries a 4% risk of potentially imminent serious complications or death. And I know these numbers are bandied around at times, but I'm always calculating. I'm driven by data. And overall, globally and across the board, it looks like 4% risk of death. And we can look at that in across ages, and again, we can see this just skyrocketing exponentially as a percent of population. So now I know I'm dealing with a population when I'm thinking about their risk that is at higher risk for contagion, higher risk to get infected, and then again, an exponentially higher risk for them to die. God forbid anybody contracts COVID at the Center on Aging and or dies from it. I'm done, washed up. I'll never get another research participant to believe that I can keep them safe ever again. And so I cannot let that happen. And I also think, when we think about risk, we also have to think, well, maybe we should just shut down entirely. Maybe we should not do any research activities. But I would like to remind everyone out there, when I look at my population who have Alzheimer's disease at various stages or other related degenerative dementias, all of them are incurable. They carry a 100% risk of death, although over a much longer period of time. So if we say 8 years, and those numbers are bandied around, 8 years, 10 years, whatever people say, we can actually look at what's your monthly risk of death from COVID. And we can plot that out. If we know that 5% of the Kentucky population is infected and 4% of that 5% potentially are going to die of COVID, we can look at that monthly rate, and we can take that from the data that's published. And then we can look at what is the risk that they're going to die of their Alzheimer's in the next month. And as you can see, their risk of death from Alzheimer's is by far greater than their risk for COVID. So this tells us that even though we have a high-risk population, we are going to need to pick potentially the lesser of two evils, and that is engaging in research. We might see the same thing in cancer research, where we have immunocompromised individuals because of their chemotherapy, and yet their risk of death from their cancer could be much, much higher than their risk of death from COVID. This is something you should be thinking about in your population, and that can help guide you to make the decision. Remember again, just because the VPR's office tells that you can open doesn't mean you should open or you have to open. It means you can. But each of us, again, remember rule number one, trust no one. Look at your population. Look at your research enterprise and decide if you can do this safely. So rule number two, create your own set of higher standards. We do not have to take the standards, the guidelines that are put out are the minimum guidelines. We should always remember that. You know, it is rare for anybody to publish guidelines that are the pie in the sky dream for each of us. So when we looked at our set of standards, we said our elderly subjects need and deserve higher levels of protections than most other study populations. And that just because death from their Alzheimer's disease may not be imminent does not mean that they should be excluded from research opportunities. And that told us that we needed to find ways to go beyond what research in other populations may be seeking to do. Again, each of you should be thinking about your own research populations. So we can think about different ways to protect against COVID-19, and this is really, really important. We know, and we've been implementing this here at the university for some time, screen for high-risk subjects, screen for folks that have been traveling to endemic areas, although now there is no travel restriction in Kentucky deemed unconstitutional, we still actually ask those questions. Why? Because it lets us stratify risks of subjects. We ask about COVID-related symptoms and the like. This is a way to begin screening. We know that maintaining social distancing can be effective whenever possible. It may not always be possible. We'll talk about that. Trying to limit the duration of a study visit could be incredibly powerful. We'll talk about that. Limiting the number of human contacts. So some of our visits might require 5, 6 staff members to interact with the patient, starting to think about, wait a minute, can we double up on some of these duties? Because if we could take human-to-human contact from 6 exposures down to 3 exposures, we would have halved the risk of spreading COVID. Use PPE, and the PPE you use needs to be appropriate for the situation, for the type of research. And then I do think we should be testing whenever and however often we can. There are other options, but you know, I'd like to just scratch those off the board. We all know they're not reasonable. So screening for COVID signs and symptoms, and each of us are filling out our employee COVID screen whenever we have to come in. We should understand that there are a wide range of symptoms reported, from mild to severe, and that as many as 50% of persons with active COVID-19, people able to spread the disease, are completely asymptomatic. But yes, we're going to look for fever, cough, shortness of breath, breathing, chills, repeated shaking, muscle pain, headache, sore throat, new loss of taste or smell. Interesting, in the elderly population, sometimes they don't have any of these. And it may simply be a worsening confusion and or behavioral exacerbation of their dementia that is the sole manifestation of COVID, at least early in the disease process. We know, though, that if we ask these questions and 50% of persons being asymptomatic, that implies the other side of the coin, that 50% of persons are symptomatic. And so just asking these questions and potentially adding a temperature check on the day of the visit is going to automatically cut your risk in half. That's good, you know. I think that's great. Every time I can cut the risk in half, I want to cut it in half. If I can cut it by a greater amount, I want to cut it by a greater amount. So Let's talk about social distancing. So we know quite a bit about social distancing currently, and the numbers, the estimates from the literature are that 75 to 93%, this is 75 to 93% effective in limiting transmission. So just those silly 6 foot apart stickers on the floor of Kroger or Speedway, or activities in the research center, maintaining social distancing, incredibly important. Much more important, actually, than those screening measures, although you need to do everything. It all adds up, and we'll talk about that. Think about your research area. Get rid of shared areas. Just shut them down. Put a border over them. Figure out how you're going to do it. We have a kitchen in our center because many people come in fasting for their visits, and typically in the past they've been allowed to go lounge in the kitchen lounge area, have a cup of coffee, have a snack after their blood's drawn, and the like. We now have laminated so that they can be sanitized menus in each of the patient's rooms where they can ask, oh, yes, I'd like this off the menu this morning. Of course, we don't charge, and they never tip us, unfortunately. But we are able, in that fashion, with immediate rooming, to eliminate the waiting area. We isolate our participants in designated rooms, obviously, and continue to sanitize between visits. And we need to understand that we can't always use a 6 foot rule. There are things that we do in research that require contact. I have to examine patients. I have to place my stethoscope on them. I have to hit them with my rubber hammer as a neurologist. And there are other activities. So blood draws, and I like this Weekly World News exclusive, an amazing new 6 foot long phlebotomy needle. Skip that. Doesn't work. We're gonna have to be hands-on, and sometimes we're not going to be able to have a 6 foot rule. We have to understand that. We have to try to maintain it, however, whenever and however we can. We can talk about limiting visit duration and exposure time. There's very little data on this, but presumably, if we take a 1 hour visit and knock that down to a 15-minute visit, we may be able to reduce infectivity. And so some of the guesstimates, the best guesstimates from science and infectious disease, are that a significant reduction in the length of a study visit could reduce infectivity by up to 50%. So we're working currently to do as much remotely before the visit and after the visit as we can to limit the amount of time that is actually spent in clinic for both participants and staff. This is incredibly important. We talked a little bit about this, but limiting number of staff contacts. This is probably one of, and many people argue, this is environmental engineering, but this may be one of the most effective ways to prevent exposure and to maintain safety. So reducing staff in clinic. And so we're all operating at a 50% staff schedule or less. If we do not need people in the building, they are kicked out and told to go home and do their work from there as well. This can help with social distancing. So we can look at this little triangle on the left. What's most effective? Well, if we could just eliminate COVID off the face of the earth, that would be the most effective sort of thing. Substitution, I'm not really sure what that's talking about, but engineering controls, administrative controls, and PPE. We can look at that, and it really is the engineering controls that are the most effective in green. So we've created this map of our center, and we have color coded each of the rooms. So there are rooms here that are in green, and those are rooms where we know a single person can enter that room, shut the door, and they are isolated socially from everything else that's going on in the center. We have rooms with little blue hearts. That's where we see patients. We know we can put the patient in there. We can close the door and keep them completely socially isolated. We know all the hallways are red, obviously, because it's hard to stay 6 feet apart when you're walking past someone in a 4-foot wide hallway. And obviously things like the kitchen conference room, copy rooms are things that we really need to take into account. And what we do is we have our staff members log in every day, and then they identify. They draw a little circle or put their initials around the room where they are for that day. So whenever anybody else enters the center, they can look and say, aha, here is where everybody is distributed. Where should I go to be able to maintain social distancing? And this also helps us to track, God forbid there ever is an exposure at the Center on Aging. It's not going to be, well, they were exposed at some time and we don't know who they really came in contact with. This chart tells us, along with some other tracking materials we have, exactly when a patient comes into the building or a staff member, who did they have contact with that day? Who is at potential risk for post-exposure tracking should we need to implement that? Further, it helps us, if we're ever audited for our safety practices, to be able to demonstrate quite clearly that we have provided a safe environment for all of our participants. This is important. I also think we talk about using PPE in appropriate ways. So, there was this big rush of only an N95, will work. My wife yesterday by FedEx got a box of N95s that she ordered in early March. Just coming in now. So what have we been relying on, and most of us? Cloth or paper masks. And, people make fun of these as well. But the latest data came out just 2 weeks ago, suggests that they are much better than previously thought for respiratory droplets. So it was previously thought they were about 80% effective. I still think 80% is great. It's what I used in my calculations. But the new data suggests that these cloth and paper masks may be 97.6% effective in eliminating COVID exposure, even when you're interacting directly with a COVID actively infected, transmissible COVID positive patient. That is incredible. Now, we do know, an ideal situation, full PPE, gown, mask, gloves, face shields, N95s or PAPRs, negative pressure isolation rooms. I don't have all that in my center. I have a selection of N95s. I've had my staff that work directly with patients sized, and they're there. Most of our work, however, is done with routine PPE, cloth, paper, surgical masks, and think about what you can do. So obviously, we're seeing plexiglass. I wish I had bought stock in it 6 months ago. We're seeing that in Charmin. We're seeing plexiglass everywhere where we go. So why not have that? A lot of the work in our rooms is cognitive testing. So I went home and bought some plexiglass and built table shields for all of my staff members. So not only are they wearing their masks on opposite sides of these shields, but this is contributing. And again, it's no one thing. There's no one thing that you can do. It is cumulative and additive safety. And please think outside the box. That could have been rule number 4. I also am a firm believer, and we see this on the news, that we should be testing everyone. We should be testing everyone whenever and however we can. But we should remember that testing in and of itself is not perfect. So from what we can tell, the nasal and or oropharyngeal swabs that are looking for active virus have a negative predictive value, a false negative rate of 3 out of every 400. So if you swab 400 people, 3 of them are going to actually have active infection, and you're going to think they're negative. So don't let your guard down, even if you are able to test people. But testing, is 99.25% effective if you test before they come into your clinic. And again, this is not just for our participants. This is if they need a caregiver with them, test the caregiver. If you can test your staff, test your staff. Blood tests are not really helpful for active exposure. They're going to tell you if you've ever potentially been exposed in the past, but we really need to be using these nasal or oropharyngeal swabs. We worked with Amy Gewurtz in pathology, infectious specialist in pathology. She recommended, rather than nasal swabbing, oropharyngeal swab. And so that is the standard of care here in our infectious disease clinic. And across, an oropharyngeal swab, for those of you that don't know, is like a strep test. You take the Q-tip, you swipe the right tonsil, the left tonsil, and the back of the throat. Hopefully, don't cause a gag reflex. Please wear appropriate PPE. So for testing, it's full PPE: gown, glove, face shield, or eyewear, N95 mask. Very, very important. And then obtain your results prior to letting folks into your clinic. As I said, our goal is 0% COVID site. I've seen a lot of pushback on this. I've seen people say that's absolutely impossible. Originally, when we started asking about this, that was what we were told. We're not ready yet, the administration. Well, we're working on this, and the administration is working on a plan, and Bob DiPaolo has been incredibly effective leading a safety restart that's not just about College of Medicine, it's about the entire campus. We have plans to actually test every single student and faculty member in the fall when classes open again. But at the time, we said, well, we really think we need testing to add to everything else that we're doing. So we leveraged our contacts, Dr. Pete Nelson and Daryl Jennings in the Department of Pathology, to look at how we can see how many tests a day are being done by those news release or the COVID blasts that Mark Newman puts out every day. You can actually track those day by day and see exactly how many tests UK is doing on a daily basis. So we asked Daryl, we said, well, how many tests do you have the capacity to do? And we checked on swab availability, and it turned out that we're testing way below our capacity, way below our capacity. So we asked if we purchase the swabs and screen all of our participants ourselves, can we do this? And the answer was, we're not going to stand in your way, but this is your activity, what you needed to do. So we were able to test all of our patients. Of course, all of our patients, our research participants are my patients. It was very easy for me just to write orders for them and to swab them. We ran into difficulties, which we're still struggling with in terms of testing our staff. But I approached Bob, Dean DiPaolo, and sat and asked with him. And I said, I have this high risk group, and it doesn't help me to screen the participants if the staff are running around infected with COVID. And Bob was extremely helpful. He said, talk to Alice Thornton in infectious disease and see if they're willing to potentially test your staff. And so we proceeded with discussions over how we could do this, and the infectious disease clinic was absolutely wonderful. Tested all of our staff, tested all of the CCTS nurses working with our folks, all of the staff members at the MRISC, everyone that our participants would come in contact with, we were able to test. The whole process, this sounds like an incredible obstacle. It took us 3 days. Of course, I was a squeaky wheel, but 3 days for us to implement universal testing. So how do we do this? Well, we actually have, for those of you that don't know where our center is, it's over on Virginia Avenue, next to Jet's Pizza by the old Lucky's Market. And we actually have a drive-through. We have a drive-through hour where people that have a visit the following day come through the drive-through, and we're oropharyngeal swabbing them. It is a problem sometimes for our disparate geographic Kentucky population. Sometimes we have folks that drive from 3-4 hours away. We've been just biting the bullet and buying them a hotel room for the night because it's that important to us that we maintain zero COVID exposure in our center. We also talked with the pathology laboratory, and we said, when are you running these tests? Because of course they're run in batches. They're not just run whenever. And we learned that if we submit the samples early enough in the morning, we actually will get the results back same day. So it is not true that it takes 24 hours to get your COVID test. It can take 26 hours if you collect at the wrong time. But again, collect the data. To date, we've only identified a single positive case. We've swabbed hundreds of participants. We've swabbed about 50 staff members. We did find a single case. All right, we can test once, but how can we test repeatedly? We know from watching the news. As a matter of fact, I've been working on repeat testing since May 30th. That's over 2 weeks now. Over that time period, there have been 4,500 new cases of COVID in Kentucky. That's a heck of a lot. That's a third of our cases in Kentucky have accumulated in the last 2 weeks. I know that I need to continue to test my staff and participants. We have been back and forth on this. The Center for Medicare Services has said that healthcare workers for the elderly should be tested weekly. We think weekly is simply impractical. We just don't think that we can do it at that level. We've settled on monthly, and this was again based on taking the data, going back, looking at the incidence rates and the number of study visits and what is the added risk of testing once monthly versus weekly that was considered quite small and acceptable for us. So we're working currently. One of the issues is we can't just flood the Alice Thornton's clinic and have thousands of researchers and participants tested there for COVID. We're going to have to learn and be able to do this ourselves within our research units. I'm working with corporate compliance with the Dean Study Start team to try to craft a consent form so that my staff members will be allowed to voluntarily, now we're not testing staff on a mandatory basis, this is purely voluntary, but if they don't test, they're provided pure remote work and are not allowed on the premises. That hopefully we'll be able to get this continued testing up and running. It's something we're all going to need. So we can go back to rule number 1 and say, all right, people may tell you that you can't do this, but again, rule number 1, trust no one but yourself and your team. Never let anybody tell you what you can and cannot do. Find the data, make the argument, make it happen. Stay calm, we can do this. And it brings me to my final rule 3, which is do everything. Don't test and do nothing else. Don't socially distance and do nothing else. Don't wear an N95 and think that that's enough to keep you safe. Every effort may be additive. It could even be synergistic. Some may be redundant, but who cares? So I can look at this and actually begin to understand the risk now at my center implementing absolutely everything. So some of this is based on assumptions. One of the primary assumptions is that the efforts are additive in my model. So we can say 5% of the Kentucky population has COVID. Well, we know staying away from those with symptoms is 50% effective because 50% of cases are symptomatic. We know that social distancing can be as effective as 93%. We know that minimizing duration of exposure may be 50% effective. We know that reducing between person exposure by limiting staff to 50% is 50% effective. We know that wearing a cloth or paper mask is 80% effective, maybe even 97% effective. And we know that interacting only with persons that have tested negative is 99% effective. So if we begin to calculate that, we can say, all right, let's do nothing to protect our research patients. And if so, 5% is the prevalence of infection in Kentucky. Therefore, your risk of if you do nothing, of getting COVID is 1 in 20. That is unacceptable. And if we know that the risk of a research participant dying or staff member dying from COVID is 1 in 500, that is way too high. I see thousands of research patients a year. I'm not going to think that it is acceptable for 3 or 4 of them to die when I could have taken safety precautions. So if we do everything, we can start adding those percentages together and identifying what the risk of catching COVID is and what your risk of dying. And so calculating this in our center, we can say, if you walk into our center as a participant, your risk of getting COVID is less than 1,500,000. And your risk of dying is 1 in 38 million. So how does that fit in perspective? Well, you know, the risk of dying from a drug overdose is actually 1 in 71. Oh my goodness, you can't even see the bar on my graph in relation to contracting COVID. How about a motor vehicle accident driving to work? 1 in 6,700. Again, you can't even see the bar. How about a mass shooting? Believe it or not, your risk of dying from COVID at my research center cannot even be seen on the graph. You are at much higher risk of dying in a mass shooting on your way to or from work. How about your risk of being hit by lightning? 1 in 181,000. By golly, you are more likely to be hit by lightning walking from the parking lot into my building than catching COVID in my center. The risk of dying of a lightning strike versus dying of COVID. By golly, the risk of dying in a plane crash, incredibly, dozens of times higher than your risk of dying from COVID from a research visit. But nonetheless, we couldn't keep up the streak. It is still safer to swim in the ocean. Your risk of being killed by a shark is actually much, much lower than your risk of catching COVID and dying in my research center. Nonetheless, that is the best that I can do. I do believe that we can do this. We can do this in the right way. 3 rules for creating a COVID-safe environment. 1, trust no one but yourself and your team. Number 2, create your own set of higher standards. Guidelines are a minimum, not a maximum. And 3rd, and most important, do everything you can to keep your participants, their caregivers, and your staff safe. And if we follow these 3 rules, it's a no-brainer. We can do this and we can defeat every other disease that we are searching for better medicines and cures for. So I'm going to end there, stop sharing my screen, and open it up to questions. So I think we've got a few here. Let me see if I can rifle down. So we do have a comment about the center working map. I highly encourage you all to draw a map for environmental controls of your area. Table shields are great. We've had several people comment that the ones that I built in my garage are perhaps some of the finest plexiglass shields folks have seen. So that made me very proud anyway to be able to do that. There's a question on who pays for the COVID testing that we're doing. We're paying for it. We have gone back to several of our sponsors, and we have asked the sponsors to pay for it. Some of the sponsors have said, fantastic, we're happy to pay. It's a minimal adjustment. The testing is relatively inexpensive, so we don't have to set up a new contract. We're well below the 10% that would require a new contract for testing. And for staff, and for research participants in studies where the sponsor will not pay, we are just paying this. We're paying this out of our residuals. We're paying it out of my endowment, where I will pay cash out of my personal bank account if that's what it takes to keep everybody safe. So really, really important. So questions about the mechanics to implement testing. This is something, that is being worked on. And I suspect, we're trying to kind of pave the way and serve as an example that can be applied to other research areas. It certainly is possible. I think what we're going to have to see is what Lisa Cassis, Jim Geddes, Bob DePaula, Phil Kern actually put together for us in terms of how we can do this practically as well. I can say that our participants and staff love the drive-through testing over at South Broadway. It's an ideal location. The issue is we're going to need somebody to staff that to open that up in a broader sense. But I do think that this is possible. So yes, we are testing all of our staff members. Everybody was tested a month ago. I am fighting right now, doing my darndest, squeaking as much as a wheel can squeak, to try to get my consent form approved so that I can repeat the testing on a monthly basis for all staff members. And until we have a vaccine or until we reach herd immunity, my intent is to continue testing every research participant on a monthly basis if they come in that frequently, and every staff member monthly. I think that we can do this as well. Remember that if you can't test, these are still powerful. Your risk of being struck by lightning, if you don't test but just socially distance, put in environmental controls, and wear a paper mask, your risk of catching COVID is less than being struck by lightning. So I didn't show you that calculation, but you may not have to test to keep folks safe. I've only met 2 people in my entire life that have been struck by lightning. And I'm sure I've met many more that have been COVID positive. I know that I am COVID negative, and that's absolutely fantastic. Whether or not employee health potentially could be used as a platform for testing is uncertain. I think that that's something we'll have to see. Phil Kern says that employee health is not doing swabs currently, that they are largely focusing on the blood-based test as well. I do think Laura Ash has a nice comment. You know, why can't nursing students be used to potentially test folks? I do think, you know, this is a campus-wide problem. This is not College of Medicine. This is not College of Nursing or College of Public Health. We are all in this together. We have tremendous resources here at the University of Kentucky. We need to be thinking, and I hope Bob and his team with the Safe Restart are looking at all of these issues. I think when they come out with a plan, it's going to be awesome. I do think we're going to need to leverage everybody. We need to pull together as a university as well. I do think, you know, there are some other questions on non-physicians. This is a real problem. So non-physician PIs, right now it is a medical test, and to order a medical test, you have to have a license to practice medicine. So this is something that's going to need to be worked into that plan. If you are a PI that would like to test and have a high-risk population, I highly suggest you add a medical staff member to your research protocol so that you might have that ability. Certainly, my slides are up for grabs, and the recorded session is there. So another question on convincing an LAR in the ICU to use a new medication or device for a family member that may have several comorbidities and be positive for COVID-19. I think, you know, really that's a question where you're going to have to look at the risks and benefits for your individual participant. I can see many, you know, it's a 4% death for somebody who's COVID positive from the COVID. Many of the medical conditions we treat have a much more imminent risk of death. Somebody who needs a pacemaker placed because they're in third-degree heart block needs that third-degree pacemaker placed, irrespective of their comorbidities or COVID-19 status. We've got to bite the bullet there. So I wish I could help you, but you know, this is a very, very important issue. Another question, implementing remote consent processes. We're working on right now remote consent for return visits. So for many of our patients that come in every 6 months or so, they're reconsented to make sure that they haven't changed capacity. We have not implemented a remote consent process for an initial enrollee in any of the research programs that are ongoing. We're using this and considering this right now simply for return visits. Many other folks have been able to implement remote consenting. The IRB will work with you on this. I think in some respects it's a matter of making sure that, you know, appropriate human subjects protections are going into the consent process. There are templates for telephone consenting of individuals. There are ways to use mail and or video technology to potentially consent. And that feeds back to one of the concepts that I was talking about, which is trying to limit that in-clinic time. So we know going through one of our consent forms is 20 to 30 minutes of FaceTime with a participant and or caregiver. By golly, if we can do that remotely, that would have a tremendous impact. So we've got everybody pulling together. Jennifer Kearns from IRB has posted remote informed consent links for everyone as well. questions on how frequently should non-high risk subjects be tested. I'm not sure. I'm not sure on that. I will say that we still need to look at this. And so when we say high risk and low risk, again, I think we have to not be thinking about the risk of death. We need to be thinking about the risk of contagion, because you may have a research subject in your study who's young, healthy, 25-year-old person who, is still immortal and doesn't even care about catching COVID. But if they catch COVID in your research facility and go home and kiss grandma, we're in big trouble. So I think we really need to be thinking about risk in a very, very real way. We need to look at our patients individually in each of our protocols. We really need to be doing all of these calculations on your own individual staff and finding out what is the best mix. You don't want to implement things that are prohibitive if they're not needed for safety. If they're needed for safety, then you want to break down the walls and do everything you can, because safety first always is the golden rule of human subjects research for us. So things are going to get better and better at UK. They already are, with the release of the phased restart plan from the VPR's office. And the restart program that Bob is working on across campus is going to be incredibly helpful for all of us as well. So with that, I think we're at the top of the hour, but I'm happy if anyone has a pressing question that we didn't get to, shoot me an email. I am on vacation this week and next week, although still, as most people, staycations just aren't what they used to be. So I'll try to do my best to get back to you as soon as possible. With that,
thank you, Dr. Jicha. We really appreciate you giving this presentation today. It really has been extremely helpful and a lot of great information for everyone. And I love your map also.
Well, thank you, Vicki. It really was my pleasure. We've presented this, and I'm working on several national COVID response in research programs for the National Institutes of Health. And again, for the International Alzheimer's Association as well. I will say, with what we're doing here in Kentucky, we're ahead of the curve. And this is not going to help now in terms of safety for patients, but sponsors are looking at this as well. Which sites can be effective in providing appropriate safety measures and minimizing disruption related to COVID? These are going to be the sites in the future. If we do this right, we're not only going to keep everybody safe, we're going to come out of this much, much, much stronger. A much, much, much more desirable site for CROs and study sponsors and extramural funding agencies, because of the leadership position we're taking as an institution.